Hello, my name is Marcus Vitaltis Trotter. I'm an orthopedic surgeon that specializes in sports and shoulder reconstruction, but I do a lot of general orthopedics as well. And we have a fun little lecture today on ACL injuries. And so just a little bit about me. So I'm not from Virginia. I was actually born and raised in Wisconsin. I was born in Milwaukee and raised about 35 minutes south in Racine, Wisconsin. I had a really tough childhood because I was a Bears fan in Packers country, which was very tough, but we lived about an hour and 15 minutes away from Chicago, and my family is from Chicago, so I'm a huge Bears fan, and so I'm very happy to see that we're actually decent in football. Growing up, I loved football, and I have a twin brother too, and we were very competitive. And so when we decided to go to college, my brother got the scholarship, and I actually had a walk-on at University of Wisconsin. And as this was at the time when they were very good, top 10, top 15 in the country. And I decided to walk on as an inside linebacker, worked very hard and was able to earn a scholarship by my sophomore year. And then I became a full-time starter and an all-conference linebacker for the Badgers. And yeah, there's a picture of me right there. And thankfully, I'm surprised they still have it, but it's been about 10 or 12 years since I played. And Camp Randall, the stadium, still has a picture of me celebrating because we have a rivalry with Nebraska. So that's pretty cool. And that's a picture of me in medical school taking a picture right next to the wall. And when I was in undergrad, I was very interested in psychology. And that was my major in college. So when I got into medical school, I thought I was going to be a psychiatrist. But things kind of changed and my plans changed. And I thought orthopedic surgery was for me. And so those logos are just the institutions that I had to go to train for my medical journey. I went to Wisconsin for college, Indiana University for medical school, University of Kansas Hospital for residency, as well as University of California, San Francisco for my orthopedic sports and shoulder reconstruction fellowship. Next slide. So I'm going to make this a simple discussion and a simple talk. You can talk about this for hours and there's a lot of debates and everything. So my goal for today is just to give a basic outline of the ACL and its corresponding injuries. So to understand the ACL, you have to understand a joint. So a joint is really just a junction between bones and it forms a socket, and that a socket allows you to move it. So for instance, in this case, the knee is the femur, the thigh bone, and the tibia, the shin bone. Now you have other articulations like the kneecap and the femur, as well as the fibula and the tibia. But for now, we're just going to think of the femur and the tibia. A ligament is a short band of tissue which spans the joint. So it originates at one bone and attaches to the other bone. And as it spans the joint, it gives passive stability. The dynamic stability that you see is typically tendons that cross the joint that are allowed to expand and contract. But ligaments are very, very important. In this case, you have four ligaments that we think of. The cruciate ligaments. What we're going to talk about is the ACL. A means anterior, C cruciate, and L is ligament. You also have the posterior cruciate ligament, which is the PCL, and then the collateral ligaments, the outside ligaments, which is the medial collateral ligament. The medial means inside, and lateral collateral ligament, which lateral means outside. Next slide. So also one thing I say, thank you for He added a lot of pictures of me playing football during this talk, which is great. So it brings me back to the old days. So that's me celebrating right there. So the ACL's main function, the primary function, is to prevent the tibia from sliding forward. When it slides forwards in relation to a joint, we say that that's anterior, hence the name anterior cruciate ligament. The secondary function is it prevents rotation, varus and valgus movements, meaning bending one way or the other, or excessive extension on the knee. It also protects the meniscus from excessive forces such as pivoting, jumping, and decelerating. The way to think of a meniscus is it's essentially a pillow within the joint that absorbs all the force of the joint and disperses it to protect your cartilage. So the ACL also protects the meniscus, which also protects your cartilage. Unfortunately, the ACL is a poor healing capacity. And so when it does injure, it cannot heal as well and scar as well as what you see in the PCL. With people who injure their ACL, there's many other injuries that can happen commonly within the joint, such as meniscus tears, other ligament tears such as the MCL tear, cartilage injuries, And all this combined can lead to arthritis later on. Next slide. This is very common in athletes, and I'm sure anyone who's watching this right now knows someone or had an ACL injury. It's typically occurring in people age of 16 to 39, but as we know, there's people even younger who sustain this injury and older as well. Females, they're at a high risk factor for these injuries, and this is a very long talk why. There's many reasons why, but the thought process is that females tend to be quad dominant. So the stronger the quad is and your hamstrings are not as strong to counteract the force, when a quad contracts, it brings the tibia forward. That puts more stress on the ACL. Also, they have knock knees, and that can place more stress on the ACL. Further, females are more likely to be ligamentally lax. What that means is, if you probably heard people say, oh, I'm double jointed, that just means that the ligaments of the joints aren't as strong and taut as other people, and so it's not able to confer the same amount of stability as someone else. And there's many other risk factors as well. Typically, when I see someone in clinic where I'm suspecting an ACL tear, it's typically someone who has an injury that's usually non-contact. They usually twist, they hear a pop, they have immediate swelling, and typically they're unable to play. Typically, if you have 2 or 3 of those in the presentation, it's about 60 or 70% chance it's an ACL tear. It can be other things as well, but that's what I'm thinking about. Once it gets to all 3, it's probably 80 to 90%. Next slide. Now, the mechanism of injury can lead to arthritis. So this has been a lot of discussion and research about this, but it is common just from the injury itself that the cartilage of the tibia and the femur can collide, and that can lead to arthritis down the road at 10 to 20 years. The common thought process is that most people with an ACL injury, whether or not they get surgery, will have a 50% chance of developing arthritis. However, when you look at those patients, probably 20-30% of those patients who do develop arthritis will be symptomatic. So a lot of these studies were looking at more of radiographic arthritis. But the thought process is, from this injury alone, it does set up the patient for an increased chance of developing arthritis and pain and functional limitations in the future. However, there's other studies that show that if you have surgery, that it might even increase your rate of arthritis. There's many factors to consider here, and this is not one size fits all. It depends on if you have any cartilage injuries at the time of injury, if you have a meniscus injury, and there's a lot of other things to play here. So the thought process, though, is there's more literature coming in recently that does show if you do get an ACL surgery, that can actually protect your meniscus and your cartilage, and they do show 10 to 20 years out that patients with an ACL surgery will have less chance of arthritis and a less chance of a knee replacement. Next slide. So for treatment, I'm in the sports world, so it's elective surgery, which means that if you don't want a surgery, you're not going to necessarily die from the pathology, right? It's whether you want to live with it, and if you're able to perform activities that you love or daily activities at a good rate. So when we think about non-operative treatment, usually it's for older patients, and that's usually patients who are 40 years old, maybe 35, but they're not that active. And it just all depends. What does that patient like to do? Are they an athlete? Do they like to play basketball or run a lot? Are they just more, at the computer? Do they have a desk job and they just like to go on elliptical? Do they have any functional limitations? Do they really have any pain after the injury? Have they tried physical therapy, NSAIDs, injections? And so there's a discussion I'll have with my patients who are older, and if they're much more active and they're not able to run or compete in marathons because they feel instability, that might push me to consider a surgery over someone who might be my age who's like, oh no, I don't really work out that much. When I walk around, I don't really feel much pain. I might reconsider a surgery. Now, when we think about a surgery, we typically advise it for younger patients, especially those who are younger than 25 years old, especially in pediatric populations, because these type of patient populations, they want to be active. They want to do things that they love, which is usually physical activities. And by doing so with an intact ACL will allow them to return to sport, but also it will protect their meniscus, which will also protect their cartilage down the road, which means, like I talked about, could prevent them from getting arthritis and a knee replacement years down the road. Next slide. Now, for surgery, again, the one thing to consider is that even if you have an ACL injury, like we talked about, you might have a bad meniscus injury. You might have a collateral ligament injury. You might have something else that needs to be fixed as well. So this is just trying to simplify it. And let's just say if someone comes in with just an isolated ACL tear, what we typically do now is we can reconstruct the ligament, which means that we take something else that is not the ligament and turn it into the ligament. There's two ways we can do this: autograft or allograft. Autograft means it's tissue from that person. Allograft means it's tissue from cadaver or a dead person. And so when would you consider to use an autograft or allograft? Typically, when we look at the studies, 40 years is typically the benchmark, but you can push it to 35 years. What the literature shows is that if you are going to operate on someone who's younger, let's say younger than 25, it's better to use their own tissue because it incorporates better and it allows the patient to go back to what they want to do with less chance of re-tear. And below on the right shows that, and this is from the Academy American of Orthopedic Surgery, that recommends this with the quality of evidence that is high. However, if you're 40 years or 45 years, the data really shows that there may not be much of a difference in terms of re-rupture rate, re-tear rate, or symptoms after using an allograft versus an autograft. If you use an allograft, the nice thing is it's a faster surgery and you have less pain, morbidity, because you don't have to make a separate incision, which occurs sometimes, and you don't have to harvest someone else's tendon. Now, what autograft options do we have? Typically, there are three that we think of: your quadriceps tendon, your patellar tendon, which you include the bone of your patella, your kneecap, and part of the bone of your tibia, your shin bone. Also, you can consider the hamstring. Now, this is beyond the scope of this lecture. There's a lot of pros and cons for both, but what has been shown through the extensive literature that has been done, that as a surgeon, if they do a great job reconstructing the ACL with any three of these autografts, the patient typically does very well. Now, what's new and what's hot in ACL surgery is this ACL repair. And so you don't reconstruct the ACL. You don't take another tendon to make the ACL. You keep the ACL as is and repair it back to its origin at the femur. Now, I'm not going to talk a lot about that. There has to be more literature that has to come out, but there are surgeons that are considering it. And it has to be the perfect patient. And that's we can talk more about that in questions and answers if needed. But right now, I think it's best that reconstruction should be considered because it has the most data and is most reliable. For return to play, it's typically 9 to 12 months, and that's extensive rehab and the patient feeling ready physically and psychologically as well. But I've worked with mentors that has pushed patients to 4 to 5 months. Now, I don't necessarily recommend that, but I just want to let people know that there's different schools of thought. But typically, when you look at the literature, it's 9 to 12 months after surgery to go back at full speed. Next slide. LET, anyone? So what this means, this is also hot in orthopedic sports right now over the last 5 or 6 years, is this understanding of the anterior lateral ligament. So it's a thickening of the outside lateral capsule, which has been shown to have a lot of more stability and an adjunct to stability in rotational movements that can aid in the ACL healing process. And essentially, it's an additional surgery you can do to essentially tighten up the lateral or the outside capsule. There's two different forms of this. Either you can reconstruct the ligament, and how you typically do that is with an allograft tendon, or you can use a patient's own IT band, which is called a lateral extra-articular tenodesis, or an LET. And that is what I do, and that is what I prefer. You take a strip of the IT band, you loop it underneath the LCL, and then you stabilize it in the femur with an anchor. And what has been shown, at least with the data now in hamstring autografts, is that it provides more rotational control, which can also decrease the chance for re-ruptures. We consider doing this surgery for people who are at risk for a repeat injury of the ACL. Those are young kids who perform pivoting, cutting sports, people who are fairly young, females is what we talked about, Also, if you see a patient and they're very loose on exam, if you're checking out the ACL and their knee is moving much more than typically what you see, people who are hyperlax or quote unquote double jointed, and there's many other things to consider here. Just how my practice is and how I was taught in San Francisco is I try to find a way to have an excuse to do this procedure for patients with ACL injury if they're younger, because the data does show that it does provide more stability and it does protect the graft, which in theory will limit the re-rupture risk, and it only adds 10-12 more minutes to the surgery. Next slide. Now there's other considerations, and again, we could talk all the time about this, but just other things to think about. Surgical timing. There's a lot of data and the quality of evidence is high that is best, if you can, to treat an acute isolated ACL tear within 3 months. The thought process here is if a patient decides to wait a year or 2 years without that ACL, the meniscus is going to assume the primary role in protecting the tibia from anterior translation or forward movement. This can lead to not only meniscal damage, but also cartilage damage and arthritis. And so we try to get to these surgeries as soon as possible, especially if the patient has their knee range of motion intact, usually 0 degrees, full extension, to at least 120 degrees of flexion. Now, people will ask me, oh, Dr. Trotter, do I need an ACL brace after surgery when I get back? There's not really a lot of evidence to support that it really does help. But my thought is if a patient, especially going back to their sport, if they feel like it gives them more confidence to at least start going back to the sport, I think that is reasonable to try the ACL brace. But the goal is sooner or later, because their knee is functionally stable, that they can be able to perform at a high level without a brace. And again, just to re-emphasize the repair versus reconstruction, now just with the data that we have, it is probably best to pursue an ACL reconstruction rather than a repair. But again, I'm opening kind of a can of worms here because that's a whole different discussion, and every sports meeting you go to, they're talking about this. So there needs to be more data on this, and I think repair maybe in the future could be consideration for some people. Next slide. And that's it. So again, this is it's a very broad topic. There's a lot that goes into it. But the goal for today was just to give a brief overview of ACL injuries, the thought process between things and other injuries that can occur with ACLs. If there's any questions that anyone has, I'm happy to answer them right now.
Thank you so much, Dr. Trotter. We will be answering questions that are live as well as questions that are submitted beforehand. Excuse me, I'm not sure why my video isn't showing.
It's fine.
Our first question today is, if my ACL is torn and my meniscus is torn, can I get them both repaired at the same time?
Yes, at least in my hands, that is 100% the case. There are times, and this is again beyond the scope of this lecture, that the meniscus may not be able to be repaired. That just depends on its characteristics, the quality of the tissue, where on the meniscus was it torn. But the way I was trained is the meniscus is just such a vital part of the knee organ to allow stability within the joint and protecting the cartilage. So whenever you have an ACL that's torn and you get a reconstruction, you better get your meniscus repaired if it is feasible. There's a lot of different types of meniscus tears, but definitely in my hands, I have a lot of patients that come in and it's not isolated ACL tears like we talk about. I mean, it's a cartilage injury, multiple meniscus tears in both menisci. It's a lot. And so for me, it doesn't matter how long it takes. I'm going to make sure that everything is repaired, because think about it. If you don't, let's say you just fix your meniscus, but you fix your ACL. I mean, the meniscus is not going to be able to sustain the forces for your cartilage, right? Or if you fix the meniscus, but don't do anything to the ACL, your meniscus most likely will not heal because it's still assuming the primary role is stability because you're ACL deficient. So it is best to have both repaired and addressed at the time of surgery, if able.
Thank you. How long after an ACL surgery can someone return to school or work? How long until they can play sports?
It depends on the patient. the pathology that we see in the surgery and what was addressed. In my hands, I am typically conservative if I do an ACL reconstruction and I fix a meniscus tear, especially if the meniscus is very unstable. But the faster the patient can walk and they're off narcotic medication, if they're feeling like their knee is okay, most likely they can return to school or work, but it all depends on what work they do. Is it heavy labor? Is it construction? So a lot goes into it. However, if I do fix a meniscus and it is unstable, in my hands for now, and things might change for me, but typically I really want things to heal. So the patient will probably not put weight on a leg for 4 to 6 weeks. And so because of that, it's much harder definitely to return to work if it's heavy labor. But for school, it's usually a week or two just to make sure they're off narcotics, everything is okay. But if they can safely use crutches, and let's say if there's a lot of stairs in the school and they have an elevator or they have other means of, counteracting that, I think it's fair for kids to go back within 2 weeks or so. But again, that it just depends on the patient, what was addressed, what work they do, and I guess the means for them, being transported and ambulating in the school.
Thank you. Is an ACL surgery an outpatient surgery?
Yes, it is. Depending on what else is performed. Let's just say an isolated ACL injury, nothing else. The surgery itself should be about an hour and 20 minutes, an hour and 15 minutes. But it takes a little bit longer just to get the patient asleep, get everything sterilized, drape the leg out, and then close the incision. So probably about an hour and 30, hour and 45 minute surgery. And so typically patients get a nerve block just so the pain is gone after surgery. And usually that wears off in 1 to 2 days. But usually it's a pretty, I want to say basic surgery, but it's a typical outpatient surgery. Yes.
Thank you. Are there any long-term limitations after an ACL surgery?
The goal would be no, because the goal is to, make the tendon that you took into your new ligament. And so the goal would be that there really wouldn't be long-term limitations. Now, you will be in pain. Any surgery you get, you will be in pain, and that'll get better over time. There's risk for any surgery that you perform. So there's risk of bleeding, risk of injury to a nerve, an artery, a vein. There's a lot of things that can, go right, but also things that can go wrong in surgery, right? But one thing we really consider for ACL surgery, especially if we do multiple other surgeries at that time, especially with someone with a big knee, they're at a bigger risk of stiffness in the knee. So I would say that's probably the biggest thing that we look at. Not necessarily the patient's going to heal the ACL, but more if they get stiffness in their knee. And so that can be a very big limitation. And so we see that in clinic at 2 weeks after surgery, 6 weeks after surgery. We really have to get the patient going to get the knee back to its functional range of motion, because if they don't at 3 to 4 months after surgery, that might mean a repeat surgery to remove that scar tissue. That's probably the biggest limitations I see. That's the thing I really coach my patients about, that we really got to get after surgery. We got to get that range of motion back. But no, the goal is that long term patients are feeling great. Now, like we talked about, there's still a chance patients still can get arthritis. That's just from the initial injury, especially if you have a meniscus tear, if you injured your cartilage, so forth. So that is still something, and an expectation a patient should understand, is that in the future, they may still develop some arthritis, whether they pursue a surgery or not.
Thank you. What does the physical therapy involve after surgery?
Yeah, so it somewhat depends again on what everything was involved in the surgery. And I have a specific protocol that I use, but a lot of it's based on the physical therapist as well, because they're the ones that's seeing the patients, right? They come just to see me to make sure the x-rays look good, their knee's doing all right. But the thought process, again, at least for me, again, if you get your meniscus fixed, or if I have to transplant cartilage, if you have a cartilage lesion as well, I'm very conservative. So for 6 weeks, you're not going to be walking, and we're going to get a range of motion back. For patients who already show at 2 weeks that they have good range of motion, I'll allow them to get the range of motion back by themselves. If there's someone I'm worried about because it's a longer surgery, a bigger surgery, let's say it's a bigger knee, I'll have them start physical therapy right away at 2 weeks to just work on passive and active range of motion. The thought process there is, in at 6 weeks, you can start walking and then proceeding with physical therapy. Now, if you don't get, again, a meniscus surgery, if you can walk right away, then you come back to clinic at 2 weeks, you start walking right away, we work on range of motion. The goal is at least at 6 weeks, you're at 0 degrees extension, 90 degrees of flexion, or even better. Then from 6 weeks to 3 months, so that's in a 6-week span, we continue to work on that range of motion to get you from 0 degrees to at least 120 degrees, have you getting stronger as you are walking, as well as start strengthening your muscles around your knee. The goal is usually, if everything is going well, around 4 months, 4.5 months, or 5 months, around that time period, you begin running. And if you are running, you're doing well, you don't have pain, the swelling is controlled, we continue to activate you to start doing plyometrics, typically around 7 months. At that time, if you're doing fairly well, the rehab will start performing functional tests to see how strong your muscles are, specifically your quadriceps, in relation to your other leg. And what they'll do is they'll typically get one at like 7 months or so. And then when you are basically ready at 8-9 months after surgery, they'll get it again. And if you have great strength in your legs, you're able to perform cutting movements, you're going back to sport specific workouts, psychologically you feel ready to go. At that time, physical therapy will clear you. So it's a good relationship that I have with the therapist, where I do the surgery, I have the basic protocol and the time point of what I want to do, but then it's really in their hands because they see the patient more in order to get them where they need to be. And if there's any hiccups down the road, then I'm aware of it and we can adjust the plan accordingly.
Thank you. It is time to finish. Dr. Trotter, do you have any last words?
No, just want to say I'm so thankful to be here, and it's been great to live my 5 months so far in Lynchburg, Virginia, and it's a beautiful place. And I'm just very fortunate that OrthoVirginia got me the opportunity to come here, and I'm here to stay. I'm really excited to treat everyone who comes through my door. And one thing I really want to say is that nothing makes me more happy than for a patient to come back to my clinic and they trusted me and they listened to our plan. We had a plan as a team to, we came up together to figure out what we can do to treat the source of the pain. And they come back and they're happy because the pain goes away. And that is from either surgery or non-surgery, right? So I have a lot of patients that come in and I don't even operate on them because they do so well without surgery. And that gives me just as much, if not more joy than the patient I operate on. So I'm just very motivated to help everyone as much as I can, no matter if it's sports or if it's for a shoulder replacement or for anyone. I'm happy to see anyone just to see what I can do to help. And again, I'll give you my full attention, and I'm just very passionate in what I do. And I promise you, if you do see me in clinic, we're going to be a team. I'm going to give my best to help you out, but I expect the same in return. And so, we're going to be a great team, and I'm excited to see everyone in clinic if they come.